So the PRISM study was a randomized phase 2 study in which we were interested in the frequency with which we give the ipilimumab component of the ipi-nivo combination, which of course is a standard frontline treatment option for patients with intermediate or poor risk advanced renal cell carcinoma. The background to the study was that, so in the registration study for the combination, the Checkmate 214 phase 3 trial, we saw that just under half of patients in that study receiving the combination experienced a grade 3 or 4 treatment related adverse event, and around 1 in 5 patients had to discontinue therapy due to toxicity. And those of us that have used the combination will be familiar with the fact that much of that toxicity is seen in the initial 12 weeks of treatment during that initial sort of induction period related to the dosing of the ipilimumab. What we have seen in kidney cancer as well as melanoma are prior studies that inform us that there is clearly a relationship between the dose of IPI and its associated toxicity. But also in lung cancer, we've seen a study, the Checkmate 012 study, where different frequencies with which the ipilimumab was given was also explored. So cohorts of 3 weekly dosing, but also 6 weekly and 12 weekly dosing of the ipilimumab. And certainly from that, it would appear that the latter cohorts were better tolerated than 3 weekly dosing. So the premise and the hypothesis for the PRISM study was that by delivering the ipilimumab less frequently within the combination, we would make the combination more tolerable for patients without compromising the efficacy. That was our hypothesis. So to be eligible for the study, patients were required to have treatment-naive, locally advanced or metastatic renal cell carcinoma with at least a component of clear cell histology, and any IMDC risk group patient was eligible for the PRISM trial. And patients were then randomized 2-to-1 in favor of a modified schedule in which patients received their ipilimumab once every 12 weeks for 4 doses in combination with Nivo, versus a standard arm in which patients receive conventional dosing, so their ipilimumab once every 3 weeks in combination with nivolumab. And the dosing that we used was standard RCC sort of dosing, so IPI 1, Nivo 3 mg per kg. In terms of the results, the study met its primary endpoint. So the proportion of patients experiencing a grade 3 or 4 treatment-related adverse event was significantly lower amongst patients receiving their ipilimumab every 12 weeks versus 3 weekly dosing. So the rates were 33% of patients versus 53% of patients with 12 and 3 weekly IPI respectively. So the absolute difference was 20%, corresponding to an odds ratio of 0.43, which was statistically significant. Efficacy formed a key secondary endpoint. Now, at the time that we designed the PRISM trial, single-agent sunitinib remained the standard of care, and hence we chose to benchmark the activity of the modified schedule against historical control data associated with patients receiving sunitinib. And we derived this from the data from the COMPARS study. The 12-month PFS rate in the modified IPI arm was 46% versus the predefined historical control rate of 39.7%. Whilst this number is therefore numerically higher in the modified IPI arm, the lower limit of the confidence interval failed to exclude that historical control rate. However, when we compare the 2 treatment arms, now we couldn't formally compare the 2 arms for efficacy in this study, given its phase 2 nature. We were not able to power the study to demonstrate non-inferiority of the modified IPI schedule. However, informal comparison shows that the PFS curves were highly comparable. There was no meaningful difference between the two treatment arms, with median PFS of 10.8 months in the 12-weekly IPI arm and 9.8 months in the standard schedule. A similar observation was seen when we considered patients with intermediate or poor risk disease only. Again, the survival curves for PFS were highly comparable, with no meaningful difference observed. When we look at objective response rates, again, we see that the response rates were highly comparable between the treatment arms. 45% objective response rate in patients receiving 12-weekly ipilimumab versus 36% in patients receiving 3-weekly IPI. And the median duration of response was also comparable at 16 and 17 months. With a median follow-up at the time of reporting of 19.7 months, clearly the overall survival data were not mature. However, if we look at a landmark 12-month overall survival, again, the rates were comparable at 88 versus 84% of patients. We then looked at the actual adverse event rates to understand that observed difference in the primary endpoint, the primary safety endpoint. And what we saw was that, in particular, we saw that rates of grade 3 and 4 arthralgia were lower in the 12-weekly IPI arm, so 7.8% of patients receiving standard scheduling versus 1.6% of patients in the 12-weekly IPI arm, which is significant since grade 3 arthralgia relates to severe pain, limiting self-care. We also saw lower rates of grade 3 or 4 serum lipase increase, so 9.4% of patients in the standard IPI arm versus 1.6% with 12-weekly dosing, and to a lesser extent, lower rates of grade 3/4 hyperphysitis and colitis. The rate of treatment discontinuation due to treatment-related adverse events was also lower in patients receiving their ipilimumab 12-weekly. So the rate was 23% versus 39% of patients receiving standard IPI scheduling. So in conclusion, we can say that delivering ipilimumab every 12 weeks instead of 3 weeks leads to a lower rate of grade 3 or 4 treatment-related adverse events. The rates were 33% versus 53%, with an associated lower rate of treatment discontinuation. In terms of efficacy, whilst we cannot formally compare the arms, we did not observe any meaningful difference in terms of several efficacy endpoints, including PFS, objective response rates, duration of response, and landmark overall survival. I think what the data mean is that whilst I don't think that they represent a change in the standard of care, I think 3-weekly dosing should remain a standard of care. It perhaps provides some reassurance to clinicians that if for whatever reason the ipilimumab needs to be delayed between doses, I think it provides some level of reassurance, as I say. But also I think what the data really do is highlight to us that we don't yet really know the optimal way to deliver these drugs to really maximize efficacy whilst minimizing the harm that is associated with the checkpoint inhibitors. I suspect that the current scheduling is not the optimal way to deliver these agents, and so I hope that really the data support that we continue to explore alternative regimens associated with the combination, and some of that work has been done and is ongoing.